Good day. My name is Jacqueline Stenson. I'm the manager of projects at the USC Center for Health Journalism. Thanks for joining us today for our Health Matters webinar, The Next Pandemic, Can We Avoid Repeating History? Bird flu has been detected in dairy cows in a dozen states, and at least 3 people have been infected. Meanwhile, new research found the virus caused massive numbers of deaths among sea mammals in South America, generating fresh concerns that a flurry of new mutations could allow the H5N1 virus to more easily infect people. These news developments can create a strong feeling of deja vu in a nation still recovering from the devastating losses of COVID-19 and eager to put the misery of pandemics behind us. But in this new era of rapidly evolving viral threats, the work of pandemic preparedness has never been more vital for averting another disaster of unthinkable proportions. Today, we'll talk about where we are in the US on that effort to bolster our readiness and what we've learned or failed to learn from the last disaster. We'll ask what further steps we can take now to avoid repeating the sharp racial disparities and unequal suffering of the last pandemic. And for journalists, we'll share insights and tips on how to smartly report on new threats amid a backdrop of persistent news fatigue and misinformation. Joining us today are 3 distinguished panelists. Mati Schlatuyo Davis, or Dr. Mati, is Director of Health for the City of St. Louis. She took over the role in 2021 and led a COVID-19 response that was honored by the Infectious Diseases Society of America and lauded by President Joe Biden. Previously, she was an infectious diseases physician at the John Cochrane VA Medical Center and Associate Program Director of the Division of Infectious Diseases Fellowship Program at the Washington University of St. Louis School of Medicine. An expert on public health and health equity, Dr. Mati is an associate editor for Disparities in Competent Care for the Infectious Diseases Society of America and co-hosts the organization's Let's Talk podcast. Jennifer Nuzzo is a professor of epidemiology and the director of the Pandemic Center at the Brown University School of Public Health. Her work focuses on global health security, public health preparedness and response, and health systems resilience. She directs the Outbreak Observatory, which partners with frontline public health practitioners on research to improve outbreak preparedness and response. Professor Nuzzo regularly advises national governments and organizations on these issues. Apoorva Mundavilli is a science and global health reporter at the New York Times, where she writes about infectious diseases. Her reporting explores the pathogens that cause these diseases, efforts to stop their spread, and the public health agencies that try to manage them. She shared in the Times 2021 Pulitzer Prize for Public Service for coverage of the COVID-19 pandemic. She was the founding editor-in-chief of Spectrum, a news site on autism science, before joining the Times in May 2020. Apoorva is the founding chair of the Diversity Committee for the National Association of Science Writers. This webinar is made possible thanks to the generous support of the Commonwealth Fund and the National Institute for Healthcare Management Foundation. We will be archiving this conversation later today at centerforhealthjournalism.org. A word about our format: we'll be hearing from our speakers first, and then we'll turn it over to our audience for questions. Feel free to share general comments in the chat. Because we have many people joining us on Zoom, we'll ask you to write your questions for our speakers into the Q&A panel. Now let's get underway. Apoorva, the bird flu outbreak has been in the news for months, but there's been a recent flurry of headlines as a few human cases have been confirmed. Can you give us a sense of where we are right now with this emerging threat?
Yeah, thank you for having me. I would like to say that we know a lot about what's going on, but I think unfortunately the situation is that we don't. We first learned about this outbreak in March, which I think was already probably 3 months after it started, maybe 2 months after it started. It's now up to 12 states, but if you looked at the USDA website, you often wouldn't know exactly where we were because the states would make announcements that weren't really yet on the USDA websites. We don't know how many people have been infected. We know of 3 cases, but only about 45 people have been tested. So there could be many more that we just don't know about. We don't know how many herds are infected. And not to give you a very dire picture here, but I think there's just a lot we don't know, considering that we've known about this outbreak for 3 months. And the communication has been patchy. I'd say it sort of depends on which organization you're talking about. I think the CDC has done pretty well so far from my perspective as a journalist. They've held pretty regular sessions for journalists, and the other agencies have too. But if you ask for information, generally the CDC has been much better about saying what they know, what they don't know, and why it's so hard for them to get more information. The USDA has been less so. I get the sense that they're not actually used to this level of attention. And so we have this situation where we need multiple agencies to really coordinate and be open and honest and working together. And I'm not sure that they've really shown that they can do that quite yet.
Thank you. Professor Nuzzo and Dr. Mati, before we dive into pandemic preparedness more broadly, how concerned are you right now about this particular bird flu virus, which appears to be mutating quickly and infecting a growing number of mammals?
Jennifer, I always cede to you, my friend. So you want to go first?
So sure. Thank you, Ati. I am quite concerned, and I'm concerned in a number of different ways. My highest level of concern right now is for the workers on the farms who we know are being exposed to this virus and who we know are already getting sick with this virus. We've known of 3 diagnosed infections, and there have been suggestions of workers experiencing similar symptoms at the same time as cows being infected elsewhere. So I am very worried about these workers. So far, the infections that have happened have been mild, but I do not see anything in the data to give me hope that future infections will necessarily be mild. I am also worried that this virus could mutate and become a pandemic threat. H5N1 has been on our worry list for more than 20 years, almost 25 years. There's a reason for it. I think the events of the last 2 years have increased concerns about this virus in particular, but it remains a threat. But before we even get to that, I think we need to be talking more about protecting the workers who are in harm's way today.
Yeah, I agree with Jennifer. But I also, being an infectious diseases doctor and admitting that my life's work is taking care of humans, right, and not animals. My colleagues in the veterinarian space, to Apoorva's point, are not used to this level of attention, right? And quite frankly, they're being asked questions that are just not appropriate for the stage. And I think that everybody is collectively also trying to learn from mistakes we made before. A lot of, especially federal agencies, were absolutely held accountable for what we can all agree was communication that could benefit from, that could have been better, right? But I do think as a person whose life's work is in ID, everything about viruses is not a monolith. It's not static, right? So they mutate by design. And so what has been positive for me in this sense is to have open communication with the CDC about the level of genetic sequencing that's happening. Our veterinarian colleagues are telling us that there's no way to predict how it will evolve at this point and if it will continue to get worse. And it's difficult to forecast, but I agree with both of my colleagues that, again, for what we've been through and the blueprint we should have to maybe be better in how we communicate, there are obviously opportunities to be better. In my role, my job is to try to make this digestible for the general public. And the challenge here is obviously that there's a dichotomy in risk, right? I love that Jennifer, because I haven't seen this enough, quite frankly, has uplifted the high risk population, which is those who do work closely with animals. They are the high risk. But on the opposite of an end of the spectrum, there is no way that I should be, and I wouldn't be doing my job, quite frankly, alarmist about the risk for the general public. And that's really hard when you think about where we've come from. So the communication and the education has been challenging, I think, for public health departments who, like Apoorva said, are waiting for more information, but who I think appropriately need to make the public understand that there is a separation of risk and how to act accordingly. So I have concern for that high risk population, obviously less so for the general population, and continue to try to learn from what we did in COVID in keeping close contact and holding our federal partners accountable to giving us more information.
Thank you. Professor Nuzzo, can you give us a sense of what you would like to see happen here in terms of disease surveillance? For instance, are we testing enough people to even know what's truly happening? I've been reading that some dairy farmers are averse to testing, which right now is voluntary.
So the short answer is no, we're not doing enough testing. I focus most of my concern about testing on the agriculture side of things because right now we are not getting a sense of which herds are infected and which aren't. And that's because testing, despite the number of outbreaks we've seen on farms, is still largely voluntary. There are some requirements now that were sort of a bit sluggish to be implemented, but nonetheless finally are implemented such that there is mandatory testing before herds are moved between states, but there's still some wiggle room there such that farmers can kind of figure out how many animals to test, etc. The bottom line is the testing that's happening on farms is not nearly comprehensive enough nor fast enough to tell us where the virus is, where it isn't, is the situation getting worse or better, and crucially, are farm workers being exposed to the virus? So that's my first priority, is making sure we increase testing there. Second priority is making sure that farm workers have easy access to testing in the places that they feel most comfortable getting that testing. The two recent cases we have identified, two of the three were found because the public health department in the state where those cases were had access to the farms and was monitoring workers that were on a farm that had been found to be infected. There was more testing going on in that state than we think is happening in other states. However, we know that this kind of monitoring effort isn't happening in other states. And part of why it's not happening is because there isn't a desire to let public health authorities come into these farms. And so what that means then is that we need to make testing available for farm workers for the purposes of allowing them to easily know if they're infected and easily access the potentially life-saving treatment that could keep them out of the hospital if they developed a severe illness. And in my view, that may have to take a backseat to our larger desire to conduct surveillance for the purpose of studying this virus. Obviously, we want to conduct surveillance for the purposes of studying this virus. But given the disincentives that exist, I don't want to use testing as a penalty to workers such that we will ultimately drive cases underground. So that's why I have that prioritized list. Obviously, if those disincentives were removed, yes, we should be following testing farm workers much more regularly. But if we just show up on the farms to test them and testing positive becomes a disincentive, meaning that they don't get to work, they might lose their job, etc., then I just don't think we're going to ultimately get the kind of surveillance we hope to get.
Mhm. And Apoorva, we're coming off several years of saturation coverage of COVID-19. How do you think about combating audience fatigue when covering new infectious threats like bird flu? And on the flip side, how do you approach covering potentially alarming developments without causing undue panic in your audience? Because must be a tough balancing act.
Yeah, it is definitely a tough balancing act. I mean, coming off of COVID, we had 3 years of nonstop coverage about a virus, and people are pretty much sick of hearing about it. And that is a con. But on the pro side, I think people have a much clearer understanding of what viruses are, the kinds of threats they can pose. People have a better sense of what it means for a virus to mutate, to evolve, and to become a different kind of threat. And they have a better idea of the kinds of things we need to protect people. PPE is like a more familiar term now. So in some ways, it's easier to cover these things because the general knowledge about viruses has gone up. But in terms of the level of alarm, it's actually very tricky because, Jennifer mentioned that H5N1 has been on everyone's radar for 20 plus years. That's certainly true for me. I've been writing about it since the early 2000s, and I've always thought of it as sort of the next pandemic, actually. So in the back of my head is always an alarm bell going off saying, oh my God, this is that moment that we were all thinking would come. But you don't want to say that to the general public because we're not there yet and we don't want to panic anybody. So what I try to do is to say what we know and why it's important that we know these things, because this could be where we are headed, but then to say again, but we're not there. And so we don't need to panic yet. And I actually always try to distinguish in the article or have some sort of quote or something that says this is something for experts to be concerned about. They are worried, they are watching. The average person does not need to worry yet. That's the message I try to get across. There is something that is of concern, but it's still at the level of experts being worried about it. When it's something that you need to worry about, we'll let you know. That's the sort of message I try to get across.
Thank you. And Dr. Mati, can you tell us a little bit about how the response you led in St. Louis to COVID-19 is informing the ongoing work you're doing to prepare for emerging potential threats such as bird flu?
Yeah, what public health went through was abominable for what we have in this country, right? Boots on the ground public health is not nearly where it should be. And so what we were doing in real time looked like what we would expect, quite frankly, in low income countries. And so I think that, losing 125,000 workers at the end of 2021, that being projected to increase to 250,000 by next year, the fact that public health workers are grossly underpaid meant that your local public health department, if we're being very honest, I mean, people in the audience can ask yourselves, could you drive to your local public health department? Do you know what they do on a regular basis? And do you look to them frequently for your information? And I don't know that that's standardized across the country, right? So what we did here was very community-based. When I took over my role in 2021, I had 2 epidemiologists for an entire city, and St. Louis, by any measure, is considered a large city. I had a budget of 36 million that only accounted for 1% of the city's budget. And we have a health department a quarter of the size of what it should be for the city. I think the things that were important to me was to have a data-driven approach that was embedded in health equity. And so we increased the number of epidemiologists. Within a year, I have 11 EPIs, and the data spoke for itself, right? Very simple metrics like zip code level data let me know where in the region we saw, and you could overlay it for every single disease entity. So when you talked about social and structural determinants of health and historic, not just current disparities, the way that we showed up mattered. I think for us, it was about then, people are tired of these buzzwords, but I have to refer to them to give you a realistic idea of what we've done that's informing what I would do if this became what some people fear it will be, is trusted messengers. Who are the trusted leaders in that field, right? Some people didn't know me from a bar of soap. I was an ID doc in a hospital. But they did know Reverend Burton in North City. They did know for children, when we did our pediatric vaccine rollout, they go to schools, right? They know they're pediatric doctors. So it was about centering those folks and then being innovative about the funds. But the reality is that my department was not empowered either by policy or by funding to do what we needed to do as the front line. So that would be the biggest thing I would need to see change for anything moving forward. And I would and we're not nearly there yet. The last thing I will say on this topic is that I don't know that people have a really good understanding of the differentiation between federal level policies, 50 states that can implement those policies, funding in different ways, and the fact that that doesn't always trickle down to the actual frontline local public health department. So that's another concern of mine.
So for both Dr. Mati and Professor Nuzzo, we saw longstanding inequities play out in virtually every aspect of the COVID-19 response. Have we made significant progress in addressing some of the structural forces behind those inequities and everything from testing to vaccines to healthcare access? Or are we poised to repeat history when the next pandemic erupts?
They just heard my voice for a while, Jennifer, so.
Oh, I was going to defer to you because you're seeing it really at the local level, and would just be curious about what your ground truth is.
So it's a nuanced question, because whether or not we've learned, if that changes how we address it moving forward is a separate question. So let me be hopeful first and then maybe go to my doomsday messaging. I was really encouraged by some of the things that we did start to do while in COVID. In the first year or so, if you looked at how we were tracking data specifically around minoritized communities across the spectrum of that definition, not just the classic racial, you saw consistently higher levels of cases, higher levels of hospitalizations, and higher deaths, right? And if you look specifically at racial demographics, we're talking 3 to 4 times more consistently, right? So that was not surprising to those of us who do this work, but definitely frustrating, because again, we've seen those same sort of disparities over and over again: diabetes, high blood pressure, stroke, all-cause mortality. So the following couple of years to start to seeing a couple of new things we hadn't seen before. For example, $6 billion that was dedicated towards community-based health equity-based measures, leaning into federally qualified health centers, community leaders, looking at pharmacy deserts and trying to prioritize pharmacies for vaccines. It was very imperfect. And there's a lot to say about how it was rolled out. It was very inconsistent, but it was the first time that a lot of us had seen those types of efforts at a federal level. So that's where I'll try to be positive, right? What is frustrating, though, is how quickly the switch was turned off once the sort of political switch was turned off, and that emergency policy that allowed people to act in an emergency state around COVID was lifted. Because what it meant was a lot of the funding that allowed us to work in the way that we needed to turned off almost immediately too, right? ARPA dollars are drying up. So a lot of these agencies that had been empowered through these novel policies and novel funding streams have lost it. So I'm now working closely with FQHCs, federally qualified health centers, and community-based leaders who are like, we took on the role of the communities that you all, quite frankly, don't care about and have never served. And now you are taking away almost instantaneously our ability to function. So they are losing workers, they are losing, and they had tripled and sometimes quadrupled their capacity, right? So that worries me about whether our intent to really care about this as a priority is in line with what we started and some of the good things we implemented.
And Apoorva, can you help us understand why poor countries' access to vaccines is also a question of U.S. pandemic readiness?
Yeah, I mean, this goes back to that thing we heard over and over during COVID, right? A threat anywhere is a threat to all of us. And that's because we saw during COVID that if you have people in another part of the world who have had no access to vaccines, that gives the virus a lot of opportunity to infect a lot of people. And that means it gives the virus a lot of opportunity to evolve. More people died in the US from the variants than they did from the original virus. And a lot of those variants started in countries where people did not have access to vaccines. If you think of, Beta and Delta and Omicron, they all started in places that, people did not have access to vaccines. In the richer countries, we had almost everybody get 2 doses before people in other countries saw even a single dose. And so that kind of inequity, I think, is short-sighted, because in the short term, it might make it seem like, oh, our people first, let's just protect our citizens, and that's fine. But we know now, and we should have known even before, that that's not how it works. Unfortunately, though, I don't know if you're all aware, but there was a pandemic treaty that was being negotiated to avoid exactly this situation. And it doesn't look like countries are going to come to any sort of agreement. It looks like, actually, if we had another pandemic, we would see very much a repeat of the kind of inequity that we saw during COVID. So in some sense, we've learned nothing since the last pandemic.
Professor Nuzzo, following up on that, do we know all the lessons we should learn from the COVID response, or is there still digging to be done on what did and didn't work? For instance, a recently published paper modeled the effects of various COVID policies in 100,000 ways, but was not able to find strong evidence on which government policies were most effective. So does this speak more to the quality of available data or to the effectiveness of policies, and how do we proceed amid this uncertainty?
So, I mean, the short answer is no. We haven't learned everything that we need to have learned. And, I'm always skeptical that these global studies could actually produce anything. I just don't think that's the best way to study these issues. I think we really have to get into the communities and when we talk about what works. Because what works in one place is not going to work in another place necessarily. And these global studies probably show us that, if anything. I think one of the biggest gaps in what we know is that we haven't had any kind of systematic audit of what happened. And it's not so much about science and policy, it's also about potentially government effectiveness. And there were so many moments in the pandemic, which, if you had any kind of insight into what was happening inside of government agencies, often you caught glimpses of barriers that were solvable, possibly related to personnel policy or resource allocation, things that we really just need to open the books on in order to know how to fix. And so I think the fact that we, kind of stand out as a country that hasn't done any kind of meaningful audit of our response to COVID just limits us in knowing what are some of the barriers that we could fix. Obviously, there are broader social issues and political issues that were challenging for us, but some of it was not necessarily having the right resources or policies within government to be able to act swiftly. And we won't know for sure unless we have a true audit. This is something that can't be done from the outside. It really requires sort of an investigation or commission to really happen. But I do want to just point to one clear lesson that I think we are very much struggling with, and it's reacting to both of the questions that you asked to Apoorva and Mati about, vaccine equity and about the inequities that we saw in communities. And I will tell you, this is one area where the preparedness field has historically failed. One of the great lessons is that we have historically developed preparedness plans for the average case and maybe had an appendix for people whose needs do not match the average case. And that's kind of there because we know it's important, but it's when we get to it, as opposed to what I think COVID clearly demonstrated is the need to center our preparedness response around our greatest vulnerabilities, to recognize that unless we, as a matter of priority, address, needs where needs are greatest, then we are not going to be successful, that we can't just have it as an app. I think we see that in terms of the global response. I tell you this, like every country for itself is just a fundamental, almost law at this point of response to global emergencies. And so we need to find a way to fix that doesn't just require donations. It's not about like politics of the moment. We see this play out over and over again. So we need new approaches, and we need to recognize that a global pandemic will not be managed if we continue to leave countries to fend for themselves. Similarly, the same thing that we saw with communities. And if there's an upside to this, is that as much as we still have to do and we still have to learn, I think at least we are talking about this in sort of more mainstream settings. I will tell you, at the beginning of the pandemic, as someone who was, frequently called to quote, to comment on what was happening, I would often get questions about the inequities that we saw in the data. And my initial instinct was to not want to be the one to comment on it because it frankly didn't feel like my field. We in academia, we have very specialized areas, and there are people that work on health equity, social justice, social determinants of health. That wasn't what I did. But I soon realized that I couldn't talk about the data in any sense of a coherent way unless I talked about these issues. So it required kind of some learning, and I'm still learning. But the data were screaming these issues. And so, if you use my personal case as a bit of a metaphor, I think the field at least is starting to see where our deficiencies are. I won't even pretend that we've solved it, but at least we're talking about it.
Yeah. Apoorva, coverage of the COVID pandemic often failed to incorporate a diverse range of experts and voices, and sometimes the voices who were quoted weren't in fact expert voices. Can you tell us a little bit about how you work to ensure your coverage isn't just spotlighting the usual suspects, so to speak, and is also quoting the most qualified sources?
Yeah, I mean, first of all, I think it's to be fair to the reporters who were working on COVID, a lot of them were not science reporters, but during COVID, people from business and entertainment and all kinds of divisions had to end up being COVID reporters. And they may not always know the difference between all the subfields of infectious diseases. They may not know that a virologist doesn't know the same things as an epidemiologist or vice versa. And so people did call maybe the wrong experts. The way that I go about trying to figure out who might actually know what they're talking about is to look at what they've done before. Obviously for something as new as COVID, that's a little bit harder because nobody had done anything on COVID quite yet, but there are other coronaviruses. And so I looked at people who had worked on SARS. I talked to a lot of people who had worked on HIV because some of that same expertise was spilling over, and a lot of HIV researchers were shifting over to working on COVID. But, if you look at something like PubMed, it's easy to tell who actually has the expertise. PubMed is the database of papers in biomedical research. And you can look and see, has this person even published anything along these lines? And that will help you avoid talking to, let's say, a nutritionist about the virulence of a virus or something like that. And so I think it's really important to get the right person. And when I write about a story, I also try to think about all the different aspects of it. So as Jennifer was saying, if you have aspects about, inequity, you don't want to just talk to an epidemiologist who does certain kinds of work about that. You also want to talk to somebody whose expertise is that particular area. And so you want to cover all the issues that you're trying to highlight in that article by going to experts in those fields. So try to have, maybe 4 or 5 voices. And in terms of diversity of sources, I maintain a spreadsheet of sources where I denote whether, people's sex, race, as much as I can know, and expertise, so that I'm not struggling on deadline to figure out whom to call for a particular issue, and that I'm also not calling only the same people over and over again. In my case, sometimes I do end up talking to some of the same people, but that's because I know they're the ones who are in the inner circle and know information that I need to know.
Yeah, that's great advice. Thank you. Dr. Mati, do you have concerns about how pandemic fatigue and all the coverage that we, listen to, that might make the work of public health officials even harder in the event of a future global threat?
Yeah, I don't think we talk enough about pandemic fatigue for the actual people who do this work. So right now, and for the last year, a lot of my focus has been internalizing what's happening with my team. I have a health department of about 150 people, but we serve an entire city, right? And so each one of the people that work for me are doing the work of 3 to 4 people. I can handle the toxicity that comes with the vitriol that came my way personally, but for people who make on average $35,000 to $60,000 a year and work absurd hours, it's just unacceptable, the type of abuse that they got. And I don't think people understand that local public health departments don't have basic infrastructure, don't have basic training and wellness programs a lot of the time in certain cities, right? And so I think that's the first place we need to talk about fatigue, is that the same people that had to respond during COVID are the ones that are going to have to do it again, and they may not have had any measure of support since then. So there's been a focus on that. We brought the first ever behavioral health bureau to the city of St. Louis under my tenure for that very reason. We talk about mental and behavioral health as a crisis before COVID. It ballooned during the pandemic, and yet we didn't have one person hired to even address this work, both internally and externally. But outside, pandemic fatigue is very real. A lot of people aren't really looking to hear from their health director or a local health department. A lot of people don't want to hear that they would have to, even address something like this. So we would have a very difficult, especially given the politicization of COVID. And Porva talks a lot about HIV. For those of us my level of my area of expertise in ID is HIV care. This is very different. If you talk to HIV providers that are around in 1985 and the 10 years afterwards, that everybody thought that was politicized. Most of, if not all of them, say this was worse, right? So how do we work with community and regain trust in order to address this in the future? This is big. And that is why, with smaller level of concerns, maybe not the one we're talking about today, but with smaller ones in between, we've been really intentional, at least in my city, about how we engage with people, having them hear our voice, understand how we bring them things that may be more alarming and not, so that they do trust that we're not always going to tell them that the end of the world is nigh when it is not. That's what it looks like at the foundational level.
Dr. Professor Nuzzo, do you have any comments on that?
I think people are tired, but I would be a little hesitant to totally dismiss people, assume that people are just uninterested. And I think part of the issue is that people are tired of being scared and not necessarily being activated. I think one of the things that we need to do when we're talking about issues is making clear what it means for them and what specifically they need to do, if anything. And otherwise, it's just like this kind of, if you haven't replaced the batteries in your fire alarm and it keeps chirping, then you just kind of drown it out after a while. Because you've assumed that it just doesn't mean anything to you. So I will not, I do think that, there's a lot of people who just kind of want to move on from the pandemic. I think part of that is equating diseases and pandemic with restrictions on their lives rather than being empowered to take actions to protect themselves that don't involve giving up the stuff that they care about. So I just want to say that I refuse to believe that people, fundamentally don't care about protecting themselves and their families. I think where we see some of the biggest challenge is when we don't give people, you know, actionable enough information to be able to do that. And if we continue to rely on advice, that's basically tantamount to saying, no, don't do that for multiple years. I mean, I think we have good evidence from other fields like HIV and actually, the greater harm reduction field, that it's about showing people how to do the things they care about more safely than necessarily telling them not to do it. And that's the only advice you have for them.
Mhm. Yeah, and of course, misinformation remains a huge challenge in communicating public health information as well. Are there lessons that any of you would like to share that you draw on from the pandemic on how to combat this huge problem, and how public health agencies can better avoid some of the blunders and get out in front of some of the bogus information and misperceptions?
So my background is being an academic, and I'll tell you that we value a certain type of person as being an expert, but I don't think we understand that experts aren't always the best communicators, right? And so there's value in not just always saying that the people that get the mic, the platform, and the bulk of the opportunities to communicate, especially around misinformation, are folks that really have no interest in it. Like most of my best friends are basic scientists or clinical researchers, and it is their nightmare to communicate. So one of the things that I think is important is to understand that communication is as expert of a tool in medicine and in science as the fact that you've published 1,000 times, right? And I think that misinformation can actually be very easily addressed if you know how to make information that is very, very inaccessible accessible to folks. And you can still address nuance and expectations and the evolution of them as such, if that is something that you have done. So one of the things I'm working on as well with academic partners is how we're training the next generation of academics about that. Sometimes you just get to give the work to the people who can communicate. It's not just as easy as the traditional way. That has been one thing that was important to me around addressing misinformation and disinformation.
From a journalist perspective, I think one lesson that I really, I had worked in autism before, so I was aware of problems with the anti-vax campaign, for example. But one thing that really drove that home even more during COVID is that their messaging is so simple. It just does not have all of the caveats and the dressing that you would expect from a scientist, which is valuable, and it's something I value, but does not go over so well when somebody wants an easy, quick answer to what they should do. And so I think that is a big part of countering misinformation, is to also come up with really simple messaging that can counter that. One thing I learned from my colleagues at the times, we had a tech desk, people were covering, myths that were coming up on social media. And I learned a little bit from them on, when to jump in and when not. Like, you don't want to jump in so early that you're actually giving oxygen to something that maybe would die away on its own. But at the same time, you don't want to wait so long that it's already taken root and you've kind of missed the boat. But the thing that I also learned from them is they would write these headlines that were just beautifully simple. It would be like, no, the Pfizer vaccine does not cause infertility. It wasn't like nuanced and pretty. It was just like, here's what you need to know. That's it. And the other thing, I think, to Mati's point about, you don't necessarily need to have the expert deliver the message. You just need to have somebody that people trust deliver that message. And I think that has actually gotten through. So I know there's a program at Harvard, and I know that the CDC is doing some stuff like this where they're actually trying to engage influencers, social media influencers, and provide good information through them, because they are where the people are. You can't just talk here and hope that everybody else hears your message. You have to actually go where they're getting their information.
Yeah, thank you. So one last question before we open it up to audience questions. So to any of our panelists, what aspects of pandemic preparedness or public health generally would you like to see more coverage of?
Well, so okay, let me jump in here and say it's not so much an aspect of pandemic preparedness, but one thing I think has not been very clear in coverage of the pandemic in stories that I tend to see is the idea that people, the federal agencies only have a certain level of agency. to do these things. That I think there's a lot of confusion about what the CDC can and cannot do. I mean, for example, if we don't know how many people are tested in this bird flu outbreak, it's not because the CDC doesn't care or is not trying, it's because they do not have the authority. And I think that sort of understanding of how there are these structural problems in the way the US is built, you know, the federal state divide, the public health medicine divide, there are all these things working against how we can respond to a pandemic. And I'm not sure that people fully understand that or talk about it enough. So I think that makes it easy to pick villains and say, oh, they're not doing their job, when actually the problem is that the system doesn't allow them to do their job.
I really appreciate that. My answer would have actually been a lot more basic. I just think that there was an interest in centering public health during COVID for obvious reasons that allowed a lot of people access and platforms. I'm actually very grateful. The reason why I'm even here today is because I believe that the media was a really great partner to me in this role and to public health. For the first time, people were interested in hearing from us, saw the value in hearing from us, but it went away. The priority has died down. So I think it would be disingenuous to be like, we're very concerned, but I'm not seeing as much coverage. We're in an election year. And when I speak to some of the people that reached out more frequently before, they're very candid in saying that the interest is just no longer there. That, you know, we don't want to talk to you guys anymore. So if we're serious about continuing this, what I think was incredible partnership to bring accessible communication from a variety of people in this space, I think you all have a platform that I hope you appreciate, in that it helped us with policy. I remember what I believe to be, and I'm speaking for myself here, were extremely xenophobic policies around the Omicron variant globally, right? In sub-Saharan countries that didn't, most of which didn't even have Omicron yet. And there were like 46 European countries at one point that had it and were able to travel in and out of the US. It was because of our partnerships with the media that we were able to bring those questions that came directly from public health to White House briefing, in the newspaper. And I believe genuinely that we were able to reverse some of those policies. If you all decide that public health isn't as important, as sexy, as much of a priority, then it goes away, quite frankly. So me, at baseline, I would say that I valued the fact that you all made public health a priority, and there were opportunities for me to talk about some of the alarmist things, but also to just do foundational teaching. I think that's important, and I hope that this is an opportunity to say, bring that back. So that would be my feedback.
Can I maybe just add to that, which is, you know, in the spirit of what I was talking about before, sort of providing actionable information. You know, I think there were clearly a lot of failures and a lot of challenges, and the nation is experiencing a lot of difficulties and polarization and loss of trust and all sorts of. There's a lot of bad news, but I also think there were a number of points of light, particularly at sort of the state and local level, that just didn't get the kind of attention that it deserved. Not to plug our own project, but we just recently, you know, launched a site called American Democracy and Health Security. And we did this because one of the things I noticed about the pandemic was when you talk to actual people, and I spent a lot of time talking to people during the pandemic, their realities were not quite as simple as some of the headlines made it out to be. Sometimes the headlines made it seem like you either cared about COVID and you were really scared about it, or you thought the whole thing was a hoax. I mean, I remember talking to this man in like very rural Texas who was deeply afraid of getting COVID, so much so that he wore an N95 mask in his own house with his own family. But he was more afraid of getting the vaccine. So it wasn't that he only cared about one or the other. He just had other issues. And just when you realize that people are complex and there's a lot more nuance out there, it just kind of makes you think that there's more things out there. And so this prompted us to start looking in states and localities to be like, okay, maybe you didn't impose a statewide mask mandate, but did you do something else? And did you think it was successful? And like, we're able to start harvesting like some pretty interesting, possibly exemplary practices that, you know, may not work for everybody, but may work for some. And so I really do think we have to harvest some of the points of light, because people are sort of, you know, tired of hearing more bad news. They don't want to just hear about a threat and then not know anything about to do with it. I think we can identify a path forward that may be more practical than what we tried before. And I really think we need to kind of shine a light on some of these potential success stories that just haven't gotten the kind of national attention they deserve. And really, I want to point to Dr. Davis for her, appropriately celebrated efforts, but just more people need to hear about those sorts of things.
Thank you all for those comments. We're going to turn to the Q&A now and take some questions from our audience. Laura Drucker asks, on bird flu, are farm workers resistant to testing because of immigration status or other reasons? And if so, are there protections in place for people to test who are not here legally? I don't know if
Short
anybody
answer
wants to
is
take
no.
We
Anita
don't.
probably knows a lot more about this too, but yeah, it's they're reluctant to test for a variety of reasons. Immigration is one of them, but they also, people don't have sick leave. They don't have employers who are okay with them taking time off to get tested, let alone to be sick and take time off to recover. They don't want anybody to know that they might have issues that might then prevent them from doing any further work. They don't want to have any sort of stigma attached to them. So there are just all of these different reasons, and no, there are not really protections in place. There is some effort by the federal government to offer money to farm owners to say, we will offer you X amount of money if you can get your workers to do XYZ, but it's I don't think it's anywhere near enough to actually get them to comply.
And on a related note, Rebecca Grapevine asks, how can reporters find out what is happening in their states with respect to testing at ag facilities? And which facilities are you most concerned about? For instance, hog, cow, chicken, or certain geographical areas or climates?
I mean, how can you find out? You would just call the Department of Health, which it doesn't always work, as you can imagine, that not every state is willing to offer information. In this bird flu outbreak, actually, it's been quite interesting to see that some states are very willing to offer up information and say, for example, we've offered PPE to a bunch of our farms and nobody wants it. Or to say, we are doing this kind of thing to try and get people tested and it's not working, or things like that. So some states are very willing. I think Michigan has really stood out in this outbreak as a state that is willing to go really the distance in trying to make sure everybody gets tested and doing all of that. If you think about, like, I think I mentioned earlier on that 45 people had been tested. I think if you start to break down, it would be like mostly Michigan. So it really depends on the state. Some states are just very secretive, but that's one way. In my personal experience, the official route is often not the most useful. So if there's a way that you can go through the outside to find somebody who is connected to the state and then from there to the state and get information that way anonymously, that's often more productive than trying to ask the official sort of public relations office, which will just give you a canned statement that means absolutely nothing. And then in terms of what am I most worried about, I've actually been trying to find out a lot about what's happening in terms of testing pigs, because as I'm sure that the ID people can tell you, pigs are the mixing vessels for viruses. So it's really important that farms are testing the pigs, because that's where, H5N1 might mix with another flu virus and pick up all the fun things it needs to start spreading in people.
Professor Nuzzo, we have a question about from Lisa Krieger. During the peak of the COVID-19 pandemic, there was a desperate shortage of personal protective equipment, the PPE. Can you speak to the current preparedness and stockpiling?
Not easily, in part because there just hasn't been a lot of transparency about that. I mean, first of all, the contents of the stockpile are is not public. There have been recent efforts to try to bolster the stockpile, but in terms of being able to gauge the sufficiency of it, I can't. And I think that's one of the things that I feel quite frustrated about. And, I'm not alone. A number of other experts have felt that some of the early messaging coming out of federal agencies around H5N1 was quite positive, like, don't worry, compared to COVID, we've got a lot of more X, Y, and Z. We also thought that when we head into the COVID-19 pandemic, that we had a stockpile of PPE, only to learn somewhat too late that it had been depleted. And so while I think there have been efforts made to look at the stockpile, I can't speak confidently that we fully have what we need, in part because there just has been not enough transparency about what's there, and it's been coupled with a description that feels a bit more like spin rather than an audit.
Public
Could
health
you-
departments have not been told to prepare. Public health departments have not been told to get PPE or anything else. And if that were needed, we have learned from COVID that public health departments need time. There's a lot of bureaucracy that goes around getting and deploying simple things. And so right now the messaging has been to focus on farm workers to get them what they need, but we have not been in any way empowered to do so. And I think that can seem like a scapegoat, but I think when there's a question in the chat around how, you know, politics drives it, all public health departments are subject to local, like we're cabinet members, right? We local budgets, policy, all of that type of stuff is all linked. So to also just say to you from a stockpiling perspective, a local public health department could not right now deploy any of those things at this time, and neither have we been asked to.
And could any of you comment on the availability of treatments for people, and if, you know, we needed treatments on a grand scale, how quickly could we make those available?
What the CDC has told us is that we can individually get treatment. Well, so what I know is that if I had to get someone treatment today, I can work with the CDC because it goes from a local to a national level. There are delays in that, but it can happen. We are also being told that there are preparations for if they were needed en masse, but that the focus right now is around genetic sequencing and how that will inform a lot of the things that they need to do to develop more vaccine and even treatment. But on an individual basis, simple en masse, I don't believe so.
But at the federal level, there are 4 antivirals that are being stored in the stockpile. And 3 of them all target the same gene. And then there's a 4th one that targets a different gene. And Tamiflu, which you might have heard of, is the sort of most popular antiviral, oseltamivir. That's really the bulk of the stockpile. But caveats to the antivirals. First of all, antivirals don't work all that well, and you have to get them within the first 48 hours of symptom onset, which is pretty tricky timing to squeeze into, especially if there are delays in even getting a hold of the drug. And then even then, you know, there have been recent reviews actually looking at this, showing that even if you get them within the first 48 hours, they may decrease the hospitalization stay by a day and a half. It's not exactly, you know, silver bullet. And on top of that, there have been instances of mutation. So there was a dolphin that had a mutation that would make the virus less susceptible to Tamiflu. There have been a couple of mutations in the cows that have been sequenced so far in this bird flu outbreak that have mutations that make the virus less susceptible to a couple of the other antivirals. So far, one antiviral, baloxavir, seems like it's you know, it still would be fine, but we only have a few 100,000 of that. So I would say I don't think antivirals are going to be the ones that save the day. I think it's going to have to come down to vaccines, which we will not have enough of anywhere in time.
And on the question of vaccines, are they being developed? Where are we with the vaccines?
Vaccine is being developed. There's vaccine right now that is available that is not as specific, and specific would be even a ridiculous term to use at this point, because what would we be targeting, right? But we have been told that most of the efforts right now are being placed into having enough vaccine available if we were to need it. But first we need to know what we know. So again, some of my frustration from the ID perspective is that we want to go to that angle first, but our vet partners, when I talk to them, are like, slow down, slow down, slow down. There's like so many caveats to this, and a lot of different places this could go from a genetic sequencing standpoint to develop the most effective vaccine, right? I want to go back to treatment as well. I think it would be an oversimplification to say that we have anything close to something that would be targeted and most people would identify with a curative treatment, whereas Tamiflu, and at least in the ID space, for example, would be on the opposite end. Like, we would never even try to make people believe that, right? But let's say they weren't prepared with something that was more like targeted curative, by the definition that I think people would want to feel safe, Tamiflu would be a disaster. Like we don't even, in the ID circles, we don't even respect Tamiflu for flu right now, right? And so again, there would have to be so much nuance in people understanding what you even mean by treatment, because the spectrum is so broad. Similarly so in vaccines. So I just want to uplift our veterinarian partners, even those at the bench, what they say about this. They are asking us to have more caution with what we're telling people is even needed or where we're going, because of how much they still need to get from it, even just a genetic sequencing standpoint.
And can I just chime in on this? Because one of the things I've been very much urging is, given all the challenges we have with surveillance and diagnosis and treatment of farm workers, I have been very much urging for us to make vaccines available to protect these farm workers. Again, goal here is to try to keep people from dying and keep them out of the hospital. When I've pushed on that, the answer that we get is that vaccines are not currently recommended for any group. My understanding is that we don't have vaccines yet that could be used, but that is currently being discussed or looked at. But I think what it points to is that there is a clear urgent need for vaccine now in this very high risk group. Finland has already announced that it's going to go ahead and start vaccinating its high risk agricultural workers. And I think the United States, it's beyond time for us to do this. Part of it is that because we just don't have it, and we need to go through a process of studying it and having FDA review it, and that'll take some time. I think what this points to the fact that in the best case scenario, if a pandemic happened tomorrow, it would be quite some time before sufficient quantities of vaccines are made available for the public. And what do we do before then? I don't think we have a real solid plan for how it would be managed. I think we're not likely to get one from the federal government. And so I think states and localities very much need to be thinking ahead about what they would do. One thing I do want to point out is that influenza is not COVID-19. And while I was not a strong supporter of Porvinosis, because she's talked to me a lot about this, about closing schools for COVID-19, I still don't love the idea of closing schools. Flu disproportionately affects kids. And we know we have fairly good data that kids often are amplifiers of transmission of influenza. And so what do we do? I mean, there's just all these open questions of what do you do? And I think that the questions have to be answered at the state and local level, because I don't think we're likely to get some kind of comprehensive policy statement.
Thank
Just
you.
add a couple things about the vaccines really quick. So we do have some vaccines. We have a few 100,000 doses that are ready to go, but they are set aside for clinical trials. So there would have to be some sort of policy change to say they can be used to vaccinate farm workers. There is a FDA approved bird flu vaccine, but as Mati was saying, it all depends on whether the virus changes enough. So right now, yes, sure, the virus as it is now apparently is still susceptible to that vaccine. But I mean, it's still a good match for that vaccine. The vaccine would work and provoke an immune response that's going to take care of the virus in its current form. But at the moment, the virus is not that good at infecting people. And if it becomes good at infecting people, the part of it that binds to the cells in people is the part that the vaccine would target. And so it's very likely that the virus will change in a way that makes the vaccine not a very good match anymore. And so that's the thing that we have to worry about. And there are actually 3 different companies and multiple platforms that already have contracts with the government to make vaccines. And now they've also been talking to mRNA manufacturers, because as we know from COVID, with mRNA, once you have the vaccine in hand, really changing the genetic sequence is a much less of an issue than with some of the older platforms. And in the meantime, just to get more doses, there is a new sort of project out where the US government has contracted with CSL Seqirus, which is one of the flu manufacturing companies, to fill and finish 4.8 million doses. And so when those doses are done, we will have that vaccine in a few months to use for farm workers or anybody else that we need, except the virus may have changed too much.
Apoorva, I'm smiling because, right, if I play devil's advocate and we were to release what they have right now, and it had 50, 60% efficacy, especially where we've come, right? Which is why it seems like I come to hedge, but I'm getting very frustrated with get the vaccine out now. And then people don't understand, or we haven't done enough to even educate folks. So I want to come back to central tenets of public health and say we should be using this time to really make people understand what I think my colleagues on this call have done a beautiful job of doing is what's the difference between influenza and COVID. Within influenza, what is H5N1? What could this look like, right? And there's so much we don't know about how it will mutate that one of the things that I'm like, we need to be fair about is if we were to release this right now and it had 50 to 60% efficacy, which we're fine with for flu, right? What does that do for the trust? What does that do for our ability to mount a response that's more specific when we need to? There is just a little bit more nuance that I think we need to have some grace for. But for me, as a public health official, it's really easy for people to be like, get everything out now. But as the person that actually has to go to the community center down the street or close, shut down a dome to implement this, and I'm the trusted messenger, the moment the efficacy isn't where it needs to be, it's another beast, right? And we haven't even talked about rural communities when we talk about inequities, for example, and how little they've been empowered, for example. So I think there's a lot we can do right now to prepare for making the public understand better the nuance around this, because these sort of absolutes around a vaccine, a treatment, a this, I think would be very ill-advised.
Well, thank you so much to all of our speakers and to the audience for all their great questions. This has been a really informative discussion. We'll be emailing everyone a survey asking for your feedback on today's program and for your ideas on other topics of interest, so please take a moment to complete it. We urge you to help support these webinars. You can find more information on the slide on how to do that. We will be archiving this webinar a little later today at centerforhealthjournalism.org. Thank you so much for joining us and have a wonderful day.